Hello, everyone. My name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet. And I'm happy to welcome you to the fifth session of the GenoMed4All and ERN-EuroBloodNet's educational program on artificial intelligence in hematology for an expert audience. This collaboration with GenoMed4All has been the result of many years working together since 2021. And this year's program aims to increase awareness of the cutting-edge advances of artificial intelligence and its implications in the field of hematology. On that note, I am happy to introduce our speakers for this fifth session. Speakers are Mar Pereira, Edward Bombiero, and Rafaela Colombati. The topic is the use cases for SCD, sickle cell disease, overview of results, both from a technical and clinical perspective, plus specific onboarding requirements. Dr. Mar Pereira is the head of Rare Anemia Disorders Research Laboratory and Translation Research, Group on Cancer and Blood Disorders at Children at Vall d'Hebron Research Institute in Barcelona. And she is also the scientific director of the European Reference Network on Rare Hematological Disorders, ERN-EuroBloodNet. Dr. Edward van Beer is an internist hematologist in Utrecht, in the Netherlands, and focuses research on rare anemias and clinical trials. He was appointed there as associate professor in 2022 and is part of many steering boards and is the task leader of several international networks and trials on these topics. Last but not least, Dr. Rafaela Colombati is a pediatric hematologist, oncologist in Padova. Her main field of interest are red cell disorders, especially sickle cell disease, and she has contributed in creating the Sickle Cell Veneto Region Reference Center in Padova and is the clinical coordinator of the local Universal Newborn Screening Program, and she is in charge of the general hematology anemias. With that introduction, I'm happy to pass the floor to our first speaker, Mar. Mar, the floor is all yours.
Thank you very much, Gavin. So as Gavin said, today we are going to talk about the second use case of GenoMed4All, that is for sickle cell disease. Different from the previous one that was MDS, now we are moving to a chronic disease, to an inherited chronic disease. And sickle cell disease is due to only a point mutation. It's a monogenic disorder that is inherited in a recessive manner. It was originally from African and Middle East countries, but it has different genotypes, and this is the main disease modifier. But also there are more than 1,000 genetic modifiers described so far. And this only point mutation is responsible for having hemoglobin S that is different from hemoglobin A, and that in conditions of low pressure of oxygen, it precipitates and it's rigid and makes the red blood cell also to change its shape and be also a rigid cell that prompt to lysis, and that also block the blood circulation. And this is what we know as the vaso-occlusive events. These are the hallmarks of the disease, and these two events, the sickling process and the hemolysis, is what will end up with a chronic inflammation and also some dysfunction of the endothelium. And altogether is like a feedback that increase the disease progression, and at the end we have a complex and interconnected physiopathological pathways that from the clinical point of view, what we can see is that is impacting at all the levels of the person. So it has a multisystemic involvement, decreased life expectancy, and we can have acute and chronic complications, and finally a low quality of life for these patients. So regarding the treatments, there is only as a curative treatment is the hematopoietic stem cell transplantation, but unfortunately is only available for around 20% of the patients. Also recently it was approved the gene therapy, but it's really very expensive. As a standard of care, also as disease modifying, there is the hydroxyurea that is normally prescribed for all the sickle cell disease patients with genotypes SS and S beta 0 from 9 months. For other genotypes, it depends on the clinical manifestations, and also related to the severity, some of the patients are under chronic transfusion therapy. But also what is important is that there are, as you can see on the right side, there are many drugs in the pipeline in different states of development that are targeting the main physiopathological pathways, as we saw in the previous slide. That is the polymerization of the hemoglobin S, the chronic inflammation, the endothelial damage, and all these complications, acute, chronic, and the organ damage. But with this scenario, some of the unmet clinical needs for sickle cell disease is the disease classification. So we don't have reliable biomarkers for classify the patients in groups according to the clinical phenotypes and the severity. The prognosis is very difficult to know when the baby is diagnosed at birth, how will be the severity, so to whom to perform a transplant or to indicate the gene therapy. Also, it's very difficult how to prevent or early diagnose the chronic organ damage. And also, we don't have any biomarker to understand the response to treatment and what would be the optimal treatment or even combination of some of these drugs for the benefit of each patient. So what are the aims in the GenoMed4All for sickle cell disease? The overall aim is to develop AI solutions to improve the clinical management through a personalized precision medicine approach, mainly based on like two strategies: omics-based classification and prognosis of sickle cell disease, and omics-based clinical decision-making in sickle cell disease. Specifically, the group identified 4 main aims. Aim 1 and 2 is to allocate the sickle cell disease patients in different groups according to their genomic and metabolomic profile, and then to assess correlation with inflammation markers and point of sickling and the phenotype of the patient. Then in a separate aim to develop a probability score using AI-based brain MRI image analysis in order to detect early the cerebral silent infarct. This will be further explained later by Rafaela. And the aim 4 is based on the results and the features that we identify as the most relevant ones from aim 1, 2, and 3 to develop predictive risk scores for the occurrence of the most prevalent and severe clinical outcomes. And for this, we firstly prioritize recurrent vaso-occlusive crisis, acute chest syndrome, and cerebral silent infarct. But still, we have some challenges for precision medicine in sickle cell disease that we need to consider also for the deployment or all the development of the GenoMed4All platform and the scalability of the solution. So as of today, personalized medicine is hampered because of the lack of high quality real world evidence. So we are not able to characterize the patient groups. Also, this ancestry, as I told you before, the mutation is original from Africa and Middle East countries, and this ancestry plays an important role in the disease risk and also in the responses to environmental exposures and the therapies. Also the heterogeneity, so due to the global movements and the countries of origin of these patients, both patients are experts are heterogeneously distributed across the EU. The clinical practice also differs a lot from one country to another country, also due to this scattered expertise. However, we know, thanks to the work that we are doing in the EuroBloodNet and the sickle cell disease expert group, that we know that between 30,000-50,000 patients are living today in EU, and that around 75% of the newborns will be screening for sickle cell disease. And this is important because we can address the needs of these patients in the next years. The first point is to have good quality data. And for this reason, 6 years ago, we started with the registry, the European Registry for Rare Anemia Disorders, that is called RADIP, with two main objectives: to enable the epidemiological and health burden surveillance of rare anemias, but also to enable the collection of enough amount of high quality real world data in order to identify biomarkers for disease progression, prognosis, and response to treatments. In this sense, and thanks to our first gathering of information, we now know how is the distribution of these patients in Europe. And as you can see, as we said before, the distribution of the patients is really very heterogeneous in Europe. And this is important for both the development of the algorithms and also the deployment of the platform and consideration on how the new data sets will impact in the models that we are developing. Not only in terms of number of patients and age, pediatric, adult, or sex at birth, but also considering, as we said before, the genotype, that is the main disease modifier. And as you can see on the left, the genotypes are distributed also in a heterogeneous manner across Europe, and also the clinical practice. Because genotype, we can incorporate this information in the model, but the clinical practice is more difficult to be incorporated. And also you can see important differences on the right on the use of hydroxyurea or regular transfusion, and all this also impact on the number of vaso-occlusive events. All this heterogeneity needs to be considered and needs to be standardized and parameterized in the data set. So what we wanted is to have a first large data set in Europe. We collected, our target was 1,000 patients. We wanted to collect clinical data, but also MRIs, the functional tests, metabolomics, and the genetic modifiers. Then for the clinical data, as I said, we are doing this following the RADIP standard that currently we are collecting data from 13 countries. We have standardized this data, and then we can reuse this data in different projects as of today in the GenoMed4All. And how we are doing this, for the GenoMed4All, what we did is to define the database, the metadata, the codifications, to develop a central database and in REDCap, and also to standardize the data in the different nodes that are participating to the GenoMed4All platform. So most of them are directly using the RADIP standard. In the case that they are not using directly the RADIP standard, we have worked on an ETL to transform the data from the data source to the RADIP standard. But what is important is that for the federation, we need to have the same standard in all the different nodes. By this, we are able to move to the federated platform. So this is the federated platform in GenoMed4All that is able to connect all the hubs that follow the RADIP standard, so the data doesn't leave the local node, but we are executing the models locally. As of today, we did this and for 5 hubs in 4 countries, as you can see, Spain, Italy, France, and the Netherlands. And you can see the number of patients, the distribution of the number of patients. And then we started working on the different type of data. So for the clinical and lab data, we collected 100, we collected more, but we prioritize for the models on recurrent vaso-occlusive crisis and acute chest syndrome and cerebral silent infarct. We prioritize 165 parameters. We ensure the quality of this data, and we did a first descriptive analysis disaggregated by age ranges and the genotypes and sex, and then to see the distribution of hemolysis-related parameters, hydroxyurea, and the number of vaso-occlusive events in order to ensure that our data set is good enough for the representativeness in the models. And the results we cannot show because it has been accepted for communication at ASH this year. So the results are under embargo, but they will be presented at the American Society Congress in December. Then for the oxygen scan, we collected the oxygen scan for 800 patients. So the inclusion criteria was patients of 2 years or more, steady state, no transfusion or acute event in the last 3 months. We explore how these oxygen scan parameters perform, the traditional ones plus 2 novel parameters, and how they correlate with severity in order to demonstrate the clinical utility. And again, the results of this analysis are in a communication for ASH and were accepted as an oral presentation. So we cannot now hear, but you will have the possibility to see the results at the conference. And finally, we are also doing an AI approach for this functional test in which, following unsupervised, we are analyzing all the raw data from the LORCA, and then we have what we call these setup parameters, that are the parameters that recreate the signal, and then we are doing some analysis with the clinical variables to understand what would be the main clinical and LORCA functional parameters in order to predict the probability of acute vaso-occlusive crisis or acute chest syndrome. So this is the way we are working. So the idea then will be to identify the features that are more important for this prediction risk for these 2 main outcomes in sickle cell disease. Then we move to metabolomics. So I'm happy to give the word to Edward.
Thank you so much, Mar, and welcome everybody to this session. I will dive a little bit more into the metabolomics, as it might be a little bit new for you. Next slide, please. So metabolomics is about the identification and quantification of small molecules and their corresponding network interactions. You can use this for disease risk analysis, monitor disease, of improving of drug management. For instance, you can measure drug metabolites. And specific subgroups, untargeted metabolomics has gained significant interest in research and diagnostics lately. I will come back to that later. And here, with this technique, we're able to measure about 2,000 metabolites at once and can help it hypothesis generating next to the other modes I just talked to you. Sickle cell disease is a very complex disease, Mar showed you already. Genetically, at least you need a single base substitution in the first exon of the beta globin gene, which is the defining mutation of the sickle cell allele. Without this, you don't have the disease, and this causes sickle cell hemoglobin to polymerize when oxygen is dissociated from it. On the left, you see figures on flow imaging cytometry on high oxygen, and on the right, on low oxygen condition, and you can appreciate the sickled formation of the cells. And in the middle, you see TAM figures of a oxygenated red blood cell, and on the right, a deoxygenated red blood cell. And you can, in the high magnification, you see the polymerase of hemoglobin really distorting the morphology of the red cell. So if you can change this, you can change the disease. Next slide. And why I'm telling you this in a talk about metabolomics in a AI-driven large cohort research to personalized medicine in sickle cell disease? Well, the reason is, if you look in this graph, you see the main players in shifting oxygen affinity. And if you look here, one of the main players is 2,3-DPG. And this is a metabolite. Next slide. So 2,3-diphosphoglycerate is, you see it here in the middle on the left, it's part of the glycolysis metabolic pathway. So this is digesting glucose into pyruvate and lactate down below and goes by various steps. And with metabolomics, we are able to measure all these intermediates at once. So we will find out which one of or correlations or ratios of these metabolites will aid us better guiding disease monitoring these patients. And also of note, you see if you see a branch on top of the glycolysis, which is called the glutathione pathway, which is also of importance because it will produce reduced glutathione to fight off oxidant stress, which is also a key player in sickle cell disease, as been shown by Mar at the start of the talk. And then here you can correlate metabolites and point of sickling, which is used with the Lorica oxygen scan, which is just pointed out by Mar as well. And there's a nice correlation between metabolites and sickling in this assay. So just to highlight how important these metabolites can be in sickle cell disease has been proven by clinical trials which aim to change this. Two compounds are in clinical development, metapivat and etavopivat, which activate pyruvate kinase and will reduce all those downstream metabolites in glycolysis. And you see here in a Dutch trial from the SCORE group that indeed these drugs are able to change the LORCA, which were also incorporated in GenoMed. In the first slide, you see point of sickling clearly dropping after giving the drug to sickle cell patients. Then on panel C, you see also metabolites changing. ATP and 2,3-DPG ratio is clearly improved by the drug, even beyond what we see in healthy controls. And this results in hematological improvement in hemoglobin, retics, plasma total bilirubin, and lactate dehydrogenase, which are all features of our model. Next slide. So is this clinically important? Yes. Also in clinical outpoint of these patients, you see that there is a reduction of vaso-occlusive events when we reduce this in patients. Also, in another clinical trial, RISE UP trial last ASH presented, you see that in the table downstairs, you see sickle cell pancreases in the low dose is reduced by about 50%, and in the high dose MEDA, it's almost 70% improvement of annualized VOC rate compared to placebo. So yes, metabolites seem to be of importance in sickle cell disease. Next slide. So if we come back to this very complex slide by Mar, I show you another important example. So on the left, you see the polymerization process. I hope you appreciate that several metabolites from the glycolysis could prove to be very helpful to identify patient risk of VOE or hemolysis. But if we look into middle, you see that endothelial dysfunction is also a key factor in the complex interconnected pathological pathways in sickle cell disease. And just a reminder for you, if red cells hemolysis, then L-arginase is released from the cell, and this will digest L-arginine into citrulline and ornithine downstream to spermidine putrescine. So this is another very important metabolic pathway. When activated, will reduce NO bioavailability. And nitric oxide bioavailability is key for good endothelial function, and probably will also promote vaso-occlusives on the run when the vessels are getting constricted. And this is also captured all with our metabolomics platform. Two other very simple examples. L-citrulline is in clinical development, can be captured, and also L-glutamine, of course, you know, it's approved for therapy in sickle cell disease in the United States, is captured with the metabolomics. So many key players in this pathophysiological network are captured by metabolomics. And then if we move to the right, you see the complex organ dysfunctions which can be caused by sickle cell disease. But many of them also have a very distinct metabolomic fingerprint, which also can be captured by this platform. Next slide. So if you look at the state of the art, what's already have been done by groups with smaller panels of metabolites or smaller patient groups, also without using the features of genomics or LORCA and the large scale of GenoMed4All, it's already proven useful. Vaso-occlusive, nephropathy, osteonecrosis, pulmonary hypertension, hemolysis, and mortality have all been associated with specific metabolites in metabolomics research. Next slide. So what are we doing now is very feasible. We just use dried blood spot with drawn blood of whole blood from a patient, and then use direct infusion high resolution mass spectrometry to measure the metabolomics, getting about 2000 metabolomic features. We then normalize and homogenize by calculating z-scores using the peak intensity of the sample of the patient minus the mean mass peak intensities of healthy controls divided by the standard deviation of mass peak intensities of healthy controls. And this allows us merging of results of various hospitals and various runs of the machine. And this has been in our effort the last months. Next. So one of the things we're tackling right now is the hematocrit variation in sickle cell disease, which also vary outcomes in metabolomics. This is just example left down below. What happens if you increase hematocrit from 0 to 100%, which obviously not physiological, but just to highlight what will happen with the dry blood spot. And on the right, you see curves, what's happening with hematocrit on the Wadman paper. So therefore, we use the 903, where there's less variation in spot size, and we are incorporating hematocrit reduction in our pre-analytical pipeline. Next slide. And here you see a quick pre-look of our data. We're currently working on it, and also this is without correction yet. But even without correction, we're already in panel B. You see clear separation of sickle cell patients and healthy controls based on identified metabolites which are different between those healthy controls and sickle cell patients. And on the right slide, you see, the panel C, you see heat map of top 25 metabolites, which probably could be incorporated in a model, but anyway, we will also use AI to identify significant features better than I've presented here with ordinary methods. And I hope that in this part I have highlighted to you that metabolomics is very promising in sickle cell disease, and we're very much looking forward to show you new results in the coming year. Thank you very much for your attention. And now I give over to my colleague, Rafaela Colombetti, who will dive into radiomics.
Thank you. So next slide, please. So why did we think to use radiomics in sickle cell disease? Well, there is one problem in sickle cell disease, which is cerebral silent infarct, which is an infarct-like lesion on the MRI of the brain. And in spite of the clinical manifestation that can be completely normal, it has some consequences. First of all, it affects 25% of the children by age of 6 and 40% by the age of 18. And it has consequences on cognition, schooling, working capacity, and quality of life. Why? Because these lesions in the brain might result in cognitive impairment, poor academic performance, and so they also have risk of future stroke. Why? Again, because there are barriers to screening in the real-world setting, and because also the pathophysiology, risk factors, and risk of progression are incompletely understood. So they represent a huge unmet need, both from a diagnostic and a treatment point of view in sickle cell disease. Next slide. And so what does radiomics do? Well, radiomics converts the digital images into numbers and data that can be analyzed. And the aim is to extract quantitative features from the images and correlate them with clinical or biological parameters. Next slide. And to do this, I'm not going to go into detail, but there is a stepwise and long process that can be done automatically or manually, and it involves the collection of the images, the pre-processing, the segmentation, the feature extraction, selection, and radiomic analysis. Now you have to imagine that every one of these steps involved months of work and continuous cross-check among experts. Next one. And in fact, what did we do? We collected, firstly, an anonymized MRI data set after performing a survey among the EuroBloodNet centers. Every image was anonymized, so we could collect them immediately when the project started, and were centralized in Bologna. And we collected more than 500 MRIs, half of which had an abnormal report. The majority were pediatric, and they were coming from different centers and performed with different types of machines. The next one. So what we developed is an algorithm that could identify the silent infarcts and tell them apart from other types of lesions in the brain, whether maturation lesions or other lesions, even if the images were performed with different machines and from different centers. So this required a stepwise process in which all the MRIs from one center were included in the algorithm, then the ones from another center, then the other from other centers, starting pediatrics, adolescent, and adult. So in this way, the algorithm could be trained appropriately, because one of the problems of algorithms is that maybe they are trained only to perform the analysis or to identify the lesion in white adult males. And when you apply the algorithm to a different population, teenagers, Black females, it might not work. So having done this stepwise process was really a way to make the algorithm more usable in different settings. The next one. And then, since this was done manually, the neuroradiologist had to identify the lesion. The AI expert developed the algorithm. Then the neuroradiologist had to check if the algorithm was performing correctly or not and eliminate false positive, false negative. Then the same algorithm was trained on different data sets, and this process was performed several times. After the training on a first set of 460 MRIs, next one, the algorithm was tested to see if it worked in a completely different set of MRIs coming from another center that was not included in the first training, and this was from Amsterdam, and both were adults, severe, mild controls, and the algorithm was again re-refined. And to ensure that our interpretation of the MRIs was correct, a blind cross-check of the same MRIs selected randomly was performed by radiologists in Padova, in Barcelona, and in Amsterdam, and the agreement was almost 100%. So this means that our algorithm was based on competence that is utilized in different real-world settings, and from different experts with different machines and different population of patients. So we believe that it's a robust algorithm, and we hope to publish the results soon.
Thank you. Thank you both, Rafaela and Edward. So as you can see, there are much in the pipeline with very interesting and promising results for the next months. So, and now we are in the moment in the GenoMed4All that also we would like to open the platform to other members that would start considering contributing to the platform and to the sickle cell disease European group. And what would be required for the onboarding is we could have both clinical sites in the EU and or not EU, but they should be GDPR compliant. Then the minimal clinical data standardized through the RADIP standard, and this includes the minimal data set, this clinical and laboratory data, but also the beta and the alpha globin genotypes, as they are the main disease modifiers, and the cerebral MRIs for the specific objective, as was now explained by Rafaela. What would be also desired, as it was presented by Edward and myself, is to have the capacity to access oxygen scan, so we can provide with more data for oxygen scan, and also to generate research real-world data, omics data sets for genomics, GWAS, or targeted NGS, and for metabolomics. But in any case, this is something that we are open for discussion. And also, I think it is important to know that the clinical sites that are already contributing to the RADIP registry, that are a high number now in Europe, they already have up to 75–80% of their minimal clinical data already standardized with the RADIP standard. So they would only need to add the new parameters that are needed for the models. So you can contact me for the onboarding on the platform. Then, of course, for any specific scientific question on metabolomics or radiomics, to my colleagues Edward or Rafaela, but for the overall onboarding directly to me. So thank you very much. I think this was the last one. Thank you very much to all of course, to the projects, to the ERN, and to the GenoMed4All, and all the experts and patients that are contributing to the sickle cell disease use case. Thank you.
Great, thank you very much. Perhaps Alexandra, did you want to open up the Slido to see if there's any questions that have come in?
Yes, the question has been submitted anonymously, and it says, what are the next steps needed to make this research and applications available for more hospitals in Europe?
Yeah, so now what we are doing is opening the platform for research. So really to now that we are doing or are finalizing the first developments and training of the models, we would like to have more clinical sites on board in order to improve the robustness of the models, because as I showed in the beginning, sickle cell disease has a high heterogeneity in Europe, so it would be great to be able to validate and retrain the models with new data sets from different patient groups in Europe. But we are in the phase of still development of the models and research. Then we need to validate, and then if really, Rafaela said, no, we will publish the results of the development of the models, and then we should then go for like a medical device and some regulatory steps for using it in the clinical settings.
Hi, Mar.
Great.
I totally agree. I think this also depends on the scalability depends on what of our futures are most promising. Is it LORCA? Is it metabolomics? Is it GWAS? So that will also play a role, I think, in scalability and in and the way how we'll implement this in clinical practice in the future.
And yes, I fully agree. And the first part is having all this clinical data standardized. So
Yes,
because
that's so important.
always the clinical data and the genotype is for sure a principal component of any model.
Great, thank you very much. I just want to take a special moment to thank each of the speakers today for their time and their expertise. Thank you very much.